How is seronegative RA clinically diagnosed? When it comes to diagnosing seronegative rheumatoid arthritis, the process can be quite detailed and thorough. Unlike seropositive rheumatoid arthritis, where specific antibodies are present, seronegative rheumatoid arthritis lacks these typical markers. This means that healthcare providers relying on a combination of clinical evaluation, blood tests, imaging studies, and the exclusion of other conditions to make an accurate diagnosis. First, a rheumatologist will conduct a detailed medical history and physical examination. They will focus on joint symptoms, looking for key clinical features. Patients often report joint pain, swelling, and stiffness, particularly morning stiffness that lasts over an hour. It's also important to note if multiple joints are involved symmetrically, which is common in this type of arthritis. The joints most frequently affected include the hands, wrists, knees, elbows, ankles, hips, and feet. Signs of inflammation, such as warmth, redness, and persistent swelling, are also critical indicators. Systemic symptoms like muscle fatigue or eye redness and dryness may accompany these joint issues. Next, blood tests play a significant role in the diagnosis. In seronegative rheumatoid arthritis, patients typically test negative for rheumatoid factor and anticyclic citrullinated peptide antibodies, which are the usual markers for rheumatoid arthritis. However, other blood markers indicating inflammation, such as elevated erythrocyte sedimentation rate and C-reactive protein, may be present. These markers can suggest active inflammation in the body. Imaging studies are another essential component. X-rays, ultrasound, or magnetic resonance imaging can help detect joint inflammation and synovitis, which is the inflammation of the joint lining. These imaging techniques can also reveal early joint damage, such as erosions or changes in bone structure, which support the diagnosis when blood tests do not show typical markers. The diagnosis relies on established criteria. This includes having at least one swollen joint that cannot be explained by another disease, a symmetrical pattern of polyarthritis, and evidence of inflammation both clinically and through imaging. The negative results for rheumatoid factor and anticyclic citrullinated peptide tests confirm the seronegative status. Additionally, healthcare providers must rule out other diseases that can mimic rheumatoid arthritis symptoms, such as other types of arthritis or connective tissue diseases. Because seronegative rheumatoid arthritis does not have specific antibody markers, diagnosis can be challenging. It often requires careful monitoring over time to observe how symptoms progress and how the patient responds to treatment. Early diagnosis is crucial, as starting disease-modifying antirheumatic drugs promptly can help prevent joint damage. In summary, diagnosing seronegative rheumatoid arthritis involves a combination of characteristic joint symptoms, negative blood tests for specific antibodies, evidence of joint inflammation or damage through imaging, and ruling out other potential causes. This comprehensive approach reflects the complex and systemic nature of rheumatoid arthritis, even in the absence of typical serological markers. Always consult healthcare professionals for personalized medical advice and guidance.